Hi, everyone, and welcome to the Think Oral Health podcast, where myself and Dr. Jonathan Levine connect the dots between oral health and overall health. I am very pleased to introduce our conversation partner for today's episode, Geoffrey Roche. Geoffrey is an inspiring and inspirational leader who brings together the topics around leadership and culture when it comes to building, training, and deploying the workforce of the future. He's the son of a nurse. He's a healthcare expert. He's a hospital administrator and a diversity advocate. And all of these hats are the roles that we will draw in our conversation today. Currently, he serves as the inaugural North America Director of Workforce Development at Siemens Healthineers. He is an accomplished speaker, a well-recognized thought leader in healthcare, and we're very pleased to welcome Geoffrey to the conversation today as one of those change makers and builder of bridges between silos in healthcare. So, Geoffrey, welcome to the podcast.
Thank you for having me. So excited to be here.
So let's start with that. Tell us a little bit about your journey and what does your current role entail as, advancing education and bridging silos for Siemens Healthineers.
Yeah. So obviously my journey really started, as a hospital administrator. That's when I started, just under a decade for a healthcare system in northeastern Pennsylvania, which now is part of Lehigh Valley Health Network. We were a standalone healthcare system for 100 years, and then we were acquired by Lehigh Valley. And that's really where I started. I was always on the external side, never clinical. And I was part of the, both our president and CEO and our chief strategy officer worked really with them very closely in both strategic advisor roles, and then also led all of our business development, strategy, government affairs, and all aspects of our community health. Then I actually, after that experience, moved into academia and served at two different academic institutions and had the privilege of serving on the president's cabinet, which, was super helpful. It's also when I started also as an adjunct faculty member in different institutions. And it was helpful because I was always focused on growing healthcare programs, but it also gave me the opportunity to really understand the academic side of that, and which was super, super cool. And then I actually moved into, was part of a founding leadership team at an ed tech company, all in the health education space. And then was fortunately, recruited to lead workforce development at Siemens Healthineers. And so in my current role, it's really, broken down to a couple facets. One is really thought leadership. How do we really, from a global and from a North America perspective, contribute into this dialogue on what's required for today, but also what's required for tomorrow? And how do we really leverage, innovative partnerships with healthcare systems, with academic institutions, with government, with philanthropy, with, a whole host of different partners at the national and at the state level to really advance equitable workforce development. And then the second piece is really how can I be leveraged as a trusted advisor to healthcare systems to really ensure they have the right ingredients to build a more sustainable healthcare workforce. And so that's really the work that I'm doing, at Siemens.
Great. I'll ask you probably to define a couple of terms for us because Jonathan and I have a definition of the workforce, the healthcare workforce, and what it entails. It is a leading question here, Geoffrey. There's no doubt about it. But how do you define the healthcare workforce or the care team from your perspective?
Yeah. So, the reality of it is if I go back to my work as a hospital administrator and all the way today, I've always defined it the same. And it really starts with the idea that to me, it's 100% interdisciplinary. It involves everyone from our allied health team, which obviously are our medical assistants, our dental assistants, all the way to other members of the team like surge tech and such. And then obviously getting into nursing and imaging, and then obviously all the way up to our nurse practitioners and our physician assistants and our physicians and really the whole team of clinicians. And so, it can be defined differently in an academic medical center environment too, because they may have different roles from a teaching and education perspective. But to me, it's 100% interdisciplinary.
Okay. And I know Johnson wants to jump in here. So Johnson, how do you define healthcare team in your practice as somebody who is actually running a healthcare oral health practice in Manhattan? Yeah.
Very similar to how Geoffrey just described it. We take a very interdisciplinary approach. We have underneath the umbrella, it's a very comprehensive approach of dental specialists, from orthodontists. I'm personally a prosthodontist, team of prosthodontists that really handle aesthetic, structure, function, and biology, this overview, especially with our new technology and the advent of cone beams, which is the CAT scans for the jaws and teeth, all the way to salivary diagnostics. But it's an interdisciplinary approach where everybody meets as teams. I know Geoffrey is deep into leadership, so I'm going to ask him some questions about that because that's near and dear to my heart of how do we, move the needle? How do you become change agents? Because there's a healthcare system that we have great opportunity to improve it. But we're very interdisciplinary within the field of dentistry. We like to think of ourselves as oral physicians, and our new focus is really helping to connect the dots between the oral health and how it connects and really can enhance both longevity and your overall health. So interdisciplinary and interconnected is very much, a part of our worlds. Yeah, so let's dive in on that. So, Jeff, here we go. Healthcare system, 20% of our GDP is healthcare. We have a sickness model. You live in this healthcare system. You're in the educational side, the leadership side. You are the perfect person to ask this question. How do we fix this system? How are we going to take a sickness model? How do we get upstream to wellness? What's your philosophy on this? And if you thought about the new technology and breakthroughs in computational science and all of our new research, how long is it going to get there? How long is it going to take to get to a better place?
Yeah, it's definitely a good question on how long it'll take, right? Because in many ways, we've been at this for quite some time. I'm definitely of the belief that we've got to shift the payer system for us to ever truly get to a model where we can make true change. And I think, we still sit at a time where we have such a disparate system, both from a payer side, from a patient side. I mean, Maria and I have talked about in the past, the idea that, if I go, even tomorrow, I'm going to go see my primary care physician. He doesn't have any clue when I saw my dentist last, what we talked about, what I may be dealing with from an oral health perspective. Now, I could tell him, right? But the reality of it is most patients may not even have the health literacy to understand those things. And so I've always believed that our healthcare system was really developed on this on the premise that if you have means, you can understand it better. If you don't have means, you're really, you're up a significant climb. And so we've got to build a system that's more people focused. And I think that starts with, I'm not going to sit here and say that I know an all payer system would be the solution, but I do think we have to have some semblance to understand that the current way of how we go about this just does not work. It's hard for people to navigate. We know there's been little to no true innovation. And frankly, if there has been, it's more like innovation that benefits those who really don't need to benefit. We have to be building this for the patients. Every day, in my opinion, we've made it harder for the patients to understand things. The EMR, should be easier, but not everyone knows. For example, a lot of practices today, you've got to use the app to book an appointment, and they won't book it even if you call. We just have made it more difficult for some patients to really understand how to do this. And so to me, people always say, do you kind of change the whole system and start fresh? In some ways, I think we're going to have to start to do that. And we've got to, I think, harness while at the same time, while we work to make these incremental steps, I think we have to harness the ingenuity that can exist in our future healthcare professionals. When I think of medical schools, why do we still have medical schools? We have nursing schools, we have dental schools. Why isn't there just one that allows everyone to learn? Yes, you have to train them, board certified, you've got to do all those things. But why have all these separate, disparate systems? Why do we have schools of public health when every one of them are dealing with public health? Now I know the answer, right? It's generally all about resources. It's all about money. It's a whole host of things, but we've got to level the playing field. And I think ultimately truly teach them interdisciplinarily, because we know that's how we should be practicing. But yet we still have a disparate system that exists. And I think until we change that, we're going to continue to have the same status quo.
Right. I love that Jonathan went there, because you touched, even in that one question, we touched on incentives, we touched on technology, We touched on education, right? So we have plenty of things to unpack there, right? And I'll let Jonathan tell you his view of why we ended with two separate schools, the medical school and the dental school. There's like, I think there's a Netflix series in the making.
It's coming.
On that.
It's coming.
It's coming, and it's on that one alone. It's probably,
well,
it's coming.
Well, Maria, truth be told, Harvard is the only school that has the dental school within the medical school.
That's right.
I will say my alma mater, Boston University, when I went there, my first 2 years was in medical school. The PhDs, the med students, the dental students were all together, and then everybody. But what's missing, and it has to do with the grand rebuke of 1840, when a couple of physicians knocked on the door and said, we want to create a dental division. They said, sorry. They put up the big hand. They said, open up your own dental school. And it's always been separate in the United States. You know, today we are learning so much. 58 systemic inflammatory diseases are linked to inflammation in the mouth. So many things, whether it's cancers, so many things show up in the mouth for early diagnosis that end up becoming these systemic issues. And so the ability for the doctors and dentists to really share information, to work collaboratively, I think you really hit on it, Jeff. When you got to start at the beginning. It's got to be part of the educational process. And you have to create protocols and systems where they're talking to each other. Mm-hmm. But let's think about it. There's the physicians can't get their act together with the universal health record. So how dentistry and medicine?
I love that point. That's right. That's just I was going to go exactly where you're going, Jonathan, because technology on its own is not the panacea to interoperability, right? And I love the statistics that came out that even in co-located clinics that have the same EHR, let's say medical teams and dental teams co-located in the same facility on Epic, even in those cases, 83% of the providers on the medical and dental side say that they don't read or they can't edit each other's notes. Mm-hmm. Mm-hmm. And so all of a sudden, what is the benefit of having Epic or EHR, the same EHR, if the behavior, again, I'm only 5% of medical on the medical side providers even open the dental records.
Yeah,
right? So the fact that it's the technology allows us to do it. Yes, there's limitation. We need to make it much more integrated. But if we are not, the mindset is that a primary care doctor who's treating a diabetic patient needs to make sure that that diabetic gets regular cleanings and the periodontal disease is under control. If that's not ingrained as a mindset, an overworked PCP is just going to do what's bare minimum and just move on to the next patient.
That's right. That's right. And then the question is, Jeff, to you, because you really understand this healthcare system that we have, is how do we get upstream to wellness? How do we get preventative? Because you were saying you wanted the nurses together with the physicians, with the dentists, and learning together and create that collaborative environment from day one when you're getting educated, because then you're going to bring that into your clinical practice. But how do we do it? Because we know that if we can get upstream to a wellness model, we'll move away from the sickness model. We're going to save billions of dollars, as our functional medicine doctors talk about all the time, and they're spot on about it. How do we move this Titanic of a healthcare system that's trillions of dollars in the United States? How could we change it? If you had your wish, what are like the top 3 things that you would say, this is what I hope for in the next decade? Because of, Maria's talking about mindset. There's a mindset shift because finally the physicians and the dentists say, we got to work together. We can't be separate. We have to work together for the improvement of care of our patients, both from an inequality and an equality standpoint. People who can afford it, and also people who are outside of that group that need us to really lean in and come up with ways to give them access to care.
Yeah, I mean, the way I look at it is, I mean, a lot of this, right, is all kind of, I mean, to me, wellness also has a huge correlation to really advancing health equity. And I think that, if you look at the current model, it's going to be very challenging for us to continue to do that within the current structure of our health insurance marketplace. Despite all the attempts that were made, with the Affordable Care Act, ultimately the industry as we always say in healthcare, follow the money, had lobbyists and others who were actively engaged to really make sure that their bottom line was healthy while at the same time our patients weren't. And
Hmm.
so, we've got to change that trajectory of this, right? I mean, I look at it from the vantage point of how do we sit in 2024 and yet all the disparate trade groups that represent, if you think about it, American Hospital Association, American Medical Association, American Nurses Association, and you could go on, American Dentistry Association.
Yeah.
Like, why is it that we can't get all of them to agree on some of these core principles and ultimately, respectfully address that and be willing to put their money where their mouth is collectively to really advance this? I think if we could get to a situation where that's the case, follow the money when it comes to lobbying, we would see changes. At the same time, I think we also have to have governors and, at the state level, at the health insurance, levels, who are willing to kind of challenge them respectfully within their states. I mean, yes, this is a federal state issue, but ultimately you've got to have some aspect that's addressing this. To your point, if we can truly focus on these things and we train our future health professionals on it collectively, we'll be in a much better situation than we are today. I mean, I look at it from the vantage point of, when I was a hospital administrator, we did oral health screenings once a year.
Yeah.
We did it during Oral Health Month.
Hmm.
And we always would talk about the fact that, it would be much better if we could have done it all the time, regularly. But the
Right.
challenge is there was no reimbursement to do it regularly. And infrastructure from a staffing end would have also been very, very challenging. But again, if we would have had a health payer who wanted to partner in that case to do something innovative, but I'll tell you, we did that regularly for a lot of screenings. I mean, we were a very robust screening type of system. Our payers were lackluster, frankly, when it came to those things. There wasn't really that interest to really truly dive into prevention and wellness.
And
Is there-
isn't it incumbent,
there's a
Marie,
disconnection.
you live in this world, incumbent upon the insurers to figure out, hey,
Oh,
if
I
we
knew
get-
that was coming my way. I knew just.
well,
throw
I mean,
it all
come
over the
on, we
wall.
got it.
It's all the pairs.
How many years of school do you need to figure out the fact that if I can get to a mouth and teach them how to brush and get them fluoride and give them some access to prevention and education, that downstream, they're not going to need decay. They're not going to end up with some terrible infection in their mouth that actually becomes life-threatening, on and on and on. How many years of education do you need?
I think there's a disconnect here in what Geoffrey is describing. And let's give credit where credit is due, right? The American Heart Association just came up with a partnership with Dr. Dan Crowley from the Delta Dental of California benefit company to bring together new guidelines of treating patients with cardiovascular issues, right? And that connection between oral health interventions and cardiovascular health. The American Diabetes Association already has guidelines around diabetic care and oral health. So, and there's like hundreds of clinical studies and peer-reviewed publications that draw the connections. So I think if step one is credibly find those clinical connections, step two is then embed those connections in protocols, clinical guidelines, right? And then step three, operationalize it. Right? I think that's where, in my view, where we have a true disconnect, because there's a gap between what the guidelines for diabetes or cardiovascular are saying, the cardiovascular care are saying, and what the general practitioner, the general dentist, or the primary care doctor is doing day in and day out, right? And part of it is absolutely a function of we get paid, we do what we get paid to do. Right. And right now, when you talk about closing gaps of care, did you have a dental visit is not in the care gaps, right? Did you have a primary care visit? Do you have a primary care doctor? Do you have an updated address? There's all the litany of things that a provider could get paid for to close care gaps. The dental part is not there yet.
Yeah.
Right. And then similarly, as a, fee-for-service dentist, taking a patient's blood pressure is part of the standard care protocols, right? How many dentists actually do it other than Dr. Jonathan Levine and the early adopters, the systemic health-oriented dentist? So, I mean, the question is, do we bridge that disconnect by more education and trying to change the mindset? Or is it truly because that's ultimately the right thing to do, right? And we've seen the dentists who do that oral systemic health approach to dentistry tend to have patients who stick with them in their practice for longer periods of time, higher satisfaction rates, like all of these side effects are there, benefit side effects are there. So how do we bridge that disconnect between clinical guidelines and the practice? Is it only payments? Is that what it is? Is that what it's going to take?
I mean, ultimately, you can never really address the social determinants, right, without addressing the political determinants. And so, I mean, I think you can, even in that situation, right, there are, providers that are doing that today, but they're not getting reimbursed for so much of it, right? And so, which then, they're doing extra work, and potentially it could even be contributing to their burnout, and whatever the case, because they have to see more and more patients depending on who's expecting. So I think, yeah, we do have to train and prepare, because I think as these additional generations come, they are going to say enough is enough. We've got to move the model. But at the same time, we've got to continue to work really to bring together a consensus of, all of these critical partners to make the change happen. And I'm just strongly of the belief that when we look at healthcare, so much of this comes down to lobbying. So much of this comes down to following the money. And ultimately, we have to have individuals at the highest levels of those associations that are willing to speak the truth. And, I think, ultimately we haven't necessarily had that. I mean, I think the most recent leader of the American Medical Association was someone who believed in systemic, health inequities very strongly, but again, his term is moved on, but he can still be, I think, without question, a leading voice. And he also in academia and academic medical, systems. And so, I think we've got to harness some of those folks, and we need to get more champions of this on both sides of the aisle. And Senate Finance has to be engaged because of the Medicare and all the, things go through there, and House Ways and Means. And we have to get people that really know how to leverage, all those types of things.
Yeah. Simple. Here's a simple fact for us, and talk about following the money. So over COVID, people were 5 times more likely to end up on a ventilator if they had periodontal disease. So classic comorbidity issues, overcharged immune response system. So when you think of that, and you think about cardiovascular disease and diabetes and all of these type of systemic health inflammatory diseases, the data sets are there of how to be preventative. What's not there is, I think Jeff's really hitting on it, is the decision makers and the people who can make the difference. There's not enough voices out there to drive those early dollars, the prevention, wellness, education dollars. Jeff, we have a foundation called the Glow Good Foundation. We go to the Bahamas. We have a 14-chair clinic. And when we went into the schools and when we educated the kids, it was very easy over an 8-year period to see the fact that they didn't end up like their parents with serious oral diseases of teeth, extractions, decay, periodontal disease, abscess. And so as we helped to clean up the adult population, we saw this great improved trend. And we go down there with nurse practitioners, dermatologists, doctors, and a whole dental specialty team, all under one roof.
Wow.
Which you start saying to yourself, wow, maybe there's something here. Maybe there's an integrated healthcare model that gets supported by the payers in the right way, that drive prevention and wellness, so that we don't end up, where we are today, where we constantly move to improve our system in every way, access and really from an economic standpoint also.
Well, I mean, to your point, if you look at the federally qualified healthcare center model, right? Many of them also have dental as part of one approach, right? But look at how they're reimbursed. They're reimbursed terribly. They're oftentimes not very sustainable, and oftentimes have to have individual philanthropic support to keep them going. And right. I think, that's a great example. If you look at the community health centers around this country, some of the best care actually comes out of them, yet how they're financed is absolutely abysmal when we truly think about it. And so, ultimately, I can remember in my hospital system, we actually tried to help start an FQHC lookalike, because, we knew some of the challenges, but the process to do that was so challenging to do it from a healthcare system standpoint. we were not able to make it work. And ultimately our board said, cut it, which is another point I'll just reference. I think the same thing that I said, from a decision-making thing also applies to the governance of our healthcare systems. Ultimately, when you look at the governing bodies of healthcare systems, directors, trustees, or shareholders, if they're for profit, they generally don't really understand healthcare. They generally have not served in healthcare. They generally, there's very little to no nurses on them. There's probably no dentists on them. There's probably very little other, colleagues from the healthcare space on them. Ultimately, they're just friends of other board members that got on there because the other board members put them on. Yet they're making the most critical decisions for a healthcare system. And ultimately, all those decisions impact lives. And so we also have to really focus on that space as well.
Mm. Maria, how about the fact, and Jeff, how about the fact that in 25 states now, nurse practitioners can do the same thing as primary care physicians? Is there some operating leverage there? These nurse practitioners, Maria and I have some amazing friends who are leaders in the innovation of nurse practitioners. Isn't this an opportunity for us to create tremendous leverage with these nurse practitioners? And how would, in your own mind, how can we integrate this into our healthcare system for the benefit of our patients?
It's a great idea, right? And keep in mind, right, the process that they had to go through to make that happen, the battles that they had to fight with the medical societies within each of the states. Here's the reality, right? We're going to continue to see significant growth in nurse practitioners. And I think, to your point, right, if there's a space where more collaboration can occur, I think it's clearly in that space without question. As you know, though, there's also reimbursement challenges still in that case as well. And so at the same time, we've got to address those things too. We as a whole have to harness the fact that programs that are growing are nurse practitioner programs. In fact, I'm pretty confident in this. The data that I've reviewed suggests that nurse practitioner programs are growing far faster than medical school programs. And I think we're only going to continue to see that, right? But what concerns me about that is rural America, frankly, because rural America access in all aspects of healthcare is truly at what I would consider to be, probably some of the worst levels ever. I mean, we're on a cliff and we're about to never get off of it. And yet, we don't have a great intentional focus on everyone to try and fix that. And it doesn't matter how many nurse practitioners we send in. If we don't have dentists there, if we don't have psychiatrists, if we don't have, other care team members, ultimately we're going to be in a significant challenge. And I think, unfortunately, we're there in many cases.
Mm-hmm. Yeah, I mean, that brings when you think of it as a system level, we talk about the integrated care approach, and a care team that is overweight on hygienists, nurse practitioners is the care team that could deliver the majority of preventative and wellness services, right? That's how you go upstream, right? That's how you take the next generation to embed healthy hygiene habits, healthy eating habits. But if you're in a dental desert or a medical desert where people who are well in their 40s who have never seen a dentist but take out their own teeth, that's where you have to be able to send specialists. And you can't really, technology has very little help in those situations other than maybe some form of triage, right? So it's great to talk about interdisciplinary care, integrated care, augmented care by technology. There's no substitute for the specialist who has gone to medical school, who has seen multiple cases, who is in there, especially for the acute cases in those dental and medical deserts. So thinking about that spectrum of needs at a system level, and how do we deploy the best resources to the patients based on what the need is? So have you, Geoffrey, from your perspective, and as you think about the future of the workforce, are you seeing any pockets in the country that are doing it well? Any initiatives that are working in that direction that you think us and our listeners could support and get more involved in? What's on your radar right now?
Yeah. I'm definitely getting super impressed with some of the innovative work that are occurring at healthcare systems regarding like youth apprenticeships. And I think there's great opportunity, even in this space to envision, when you have a situation where, particularly as an academic medical center, and they, to your point, whether they have a dental school that's separate or a dental school that's in a medical school, you know, why not, give them that opportunity to experience those, that full interdisciplinary approach. And so the University of Wisconsin Health, for example, their director, Bridget, has done an amazing job of developing some amazing youth apprenticeship programs in many areas of allied health. And I know, she's basically doing it based on needs and then growing it so that they, these are youth that are getting defined roles, actual jobs in the healthcare system, and they're working, in these roles with the intention then to get them further educated and get them retained. And I think we've got to do those types of things. I look at it from the vantage point of, when people think of medical, right? They usually think doctor, nurse. Even if you think of dentistry, you always really pretty much go to the dentist, right? You don't think of the dental assistant or the other care team members. I spend more time with a dental assistant or other members of the team, dental hygienists, than I actually do with the dentist. I'm not saying that to be mean. It's just the truth. The dentist comes in and just checks my teeth at the end, if I'm healthy, right? Whereas the dental hygienist, in my practice, actually, they do take my blood pressure. So I'm excited, about that. And I will say they also review other aspects. For example, now some of that is because I've told them my medical history, right? But they do review it at every appointment, even though I'm telling them. So, I think we have got to do more of these types of initiatives because we have to train our youth that become our future workforce on the full social determinants of health, on all the aspects of health equity. And we also have to your point, train them and teach them that everything that we do, within the mouth also impacts all aspects of our health. We know it, right? We know it: cancer, heart disease, diabetes, other, aspects. And we've got to change the system. And at the same time, I do believe we also have to be willing to try new things. And so I'm encouraged. For example, Maria, I've seen all the great, startups that you've brought, and helped coach into the system. The challenge I see for so many of the startups, though, is, they're trying to come and fix a broken system. And so sometimes it's also just hard to get into a broken system because while we know, most of us know it's broken, some of the people are just defensive about it. They don't want to be willing to change it. The industry that's the hardest for a startup to actually be successful in my opinion, is healthcare, because we're risk averse. We're so slow to act. And even though we know the crisis is here, so many people are just out, we're just humming along. And so all of us also have to help to get these startups into the space to help be successful. And I hope that we'll see more health insurers launching some of the innovative startup work that they've done. If we can see more of that, supporting these startups, then we can have some systemic change because they're the payer. And ultimately, if you're a hospital and you've got a payer saying, hey, we want you to try this, then, I think it's a little different story.
Yeah. It's such a great point. It's such a great wrap. In dentistry, one of the areas that we're overlapping in spite of everybody is sleep diagnostics, because we own it now through CAT scans for the jaws that are becoming a standard for many dental offices. We can see upper airway restriction, which allows us to ask more important questions, concerning sleep, because if you can't get into deep sleep, you can't prepare your body. You can't repair your body. You can't fight cancers, hypertension, cardiovascular disease, and all the rest. And so the doctors and dentists really have to collaborate. And that has come out of new technology, almost some unintended consequence. The fact that CAT scans, cone beam, computer tomography is now in dental offices. From the top of the nose, we're looking at sinuses. We understand airway restriction, make a referral, ear, nose, and throat. Upper airway problem, maybe a better answer than what's currently in medicine called CPAP. So what you're saying is so true. And the hope that the payers and the decision makers start opening this conversation in a much bigger way, but also driven by an undercurrent of this technology and the impact and the rounds of return that new technology and new research really gives us. And that will keep us hopeful, right, Maria?
It's all about keeping us hopeful, because otherwise this is a very complicated, very lopsided, incentivized industry that, I do believe that even though there's multiple perverse incentives in the system and that complexity was man-made. We all created it over the years.
Mm.
I do believe that everybody in the healthcare ecosystem is operating from best intentions at heart.
Yes. Yes.
But they have a different level of tolerance for change or capacity to influence or drive change. So no one really wakes up one day and thinks, what is the most convoluted, most expensive, and time-consuming way I could process claims? Let me just institute fax machines, right? That's not how somebody wakes up and starts their day. But yet we are here because over the years, all that complexity, legacy systems, we've always done it that way, that kind of mindset, that kind of legacy. We've just taken on that complexity debt and kept adding to it rather than saying, time out, why are we doing this, right? Can we take a 12-step process and turn it into 2, right? And that we're not seeing a lot of that thinking because there's not much of agency, right? I mean, a lot of it is like, well, my job is to see the patient and make sure I see them in 15 minutes and get them out of here with as many factors, diagnoses that I could get. So that would impact my revenue generating units as a primary care doctor. And so that's the behavior that we all find ourselves into. And we don't necessarily intentionally set out to do that. And sometimes that awareness is all we need. I do want to end on a positive note. We're trying. This has been, because Jonathan started this with, how do we fix this? We had to go into the bowels of what's wrong.
We had to unpack. We had to
unpack. So Geoffrey, what's next for you in terms of your amazing work that you're driving within Siemens and outside of Siemens? And if our listeners want to follow you, get involved, stay in touch in all the amazing initiatives that you're driving, what's the best way for them to do that?
Yeah. Best way to connect is obviously on LinkedIn. Always happy to connect. And to your point, I mean, there's definitely a lot that's, on the horizon, really regarding, looking at, to your point, being that bridge between higher ed and healthcare to try and really lead some systemic changes and really more innovation and transformation around, topics like apprenticeships. And, I think we have a lot of work to do in our K through 12 system to also just educate them on all these roles and how they can be the future dentist, or they could be the future dental hygienist. They could be a primary care physician that also cares about, oral health. We've got to, do a lot of work in that space. And I think, particularly that's a space that we haven't done a lot of great work in. And the other piece, to your point is, I'm also very involved in supporting the nursing profession too. As you know, I'm a commissioner on the Nursing Commission because we've got to change the way that that's handled as well. And so, I think similarly, we've got to bring all these things together and advance it with a systemic health in mind, both for our patients, but also for the workforce.
I love that. And please, my personal invitation to all our listeners is, if you are one of those cross-disciplinary specialists who has a hygiene degree and a dental degree, or a nursing degree and a hygienist degree, if you're one of those hybrid unicorns out there who are practicing that integrated care, reach out to us, any of us. We'd like to know your story, would like to capture some of your best practices, and would like to give you a voice of some of the great things that you're doing. Because these are the types of practitioners, the clinicians, the providers that are out there. We want to give a voice and spotlight them.
Yeah, it's great. You really define, Maria, the heroes of the healthcare system, because they're the people who are they're change agents. And Jeff, you fall in that category. I want to thank you so much for coming here, for sharing your thoughts. It was really a great conversation. We know that we're at the beginning of this fight, really, even though it's a number of decades working on it. And we'll just keep this conversation going and keep doing all the great work that you're doing is my thoughts.
Thank you very much. I appreciate it.
Yeah.
Thank you for joining us. Until next time.